Okay. So welcome all guys and welcome to this session of anatomy topics over here. And today we are going to discuss some very important topics from the topic of head and neck, right? So topic today is side of the neck. Side of the neck is the topic that we are going to discuss today. So welcome to this session. These sessions over here, they are just a second. Yeah, they are final intensive revision series over here, 45 days. And beneficial not just for university exams but also for all the our competitive exams like NEET, PG, and other exams. Let's see the topic over here which are going to be discussed. So there are some long essay questions and there are some short essay questions. And these questions over here are the previous year questions. So remember, these are actually the PYQs, which obviously become very, very important. And these are mostly recent PYQs of just few years back. So long question that we are going to discuss today is about the posterior triangle of the neck. So one topic that we will be covering is the posterior triangle of neck. We all know why it is so important. We'll discuss it. And other topics that we are going to discuss today is a little, some students regard it as a little complicated. It is basically deep cervical fascia, but today we'll understand it in a very simplified manner so that after today's session, if you revise it again, you will be confident in this particular topic. And then part of DCF, we have the carotid sheath as another topic, and also talk a bit of the external jugular vein, which is located on the superficial aspect. So these are the topics that we are going to discuss today's session. Why choose Auricle? Very good question. Should come to your mind that, okay, why should I go with Auricle? So these are all the benefits of Auricle which are written over here. You can even take the screenshot. You are having the recorded classes. You're having the live classes right now. What you're having, you'll have the practical sessions as well. You're having the exam modules, and you also get a hard copy book set. Now, let me tell you, this hard copy book set over here is a beautifully crafted books. The notes in that hard copy are based on question answer format. Okay, so question and answer format, we have the notes. We also have MCQs. We also have those fun zones, images, and everything is over there, right? So it is quite a good piece of hard copy book set that you will get. Recorded classes, these are all the features of recorded classes. You have the flexible learning. Obviously, not all of you can attend the live classes because of your personal commitments to your college, home, etc. here and there. So it gives a flexibility in learning because the learning should continue. You have expert instructions, so you obviously get instructions, and you get a convenient revision time as well in this recorded classes. Live classes, obviously, you can ask the doubt. So you have in-depth coverage over here. You have the experienced educators, and you have interactive learnings. Interactive learnings, and there's a two-way exchange of ideas, exchange of thoughts, exchange of topics in the session. That is what is known as a two-way, right? Interactive learning. So that is a benefit. Exam modules over here. Okay, so Auricle exam module is meticulously designed to cover the entire syllabus in just around 20 hours. So this is beneficial actually to those who have covered up the in-depth session. Then you have the exam modules. So the entire syllabus can cover up in just a matter of 20 hours. 20 hours, like was a 3-4 days of hard work will get you through it, right? So we have a strong emphasis, most of the educators over here, on answer writing skills. Like, for example, if you go to the last week's session of mine, not just mine in anatomy, but even in physiology and biochemistry, Auricle did a session on how to write answers, right? How to solve a question paper as a theory exam question paper. And that I also discussed that what are the important things apart from academics that you have to keep in mind when you are giving a theory exam. So that is actually applicable not just to one particular subject, but to all the subjects in whichever year you are, right? So there are some basic things which one should know. So you can have a look at that session if you haven't yet, right? So we have interactive sessions and focus on exam strategies, right? So we have syllabus in 20 hours, answer writing skills, and obviously expert. Why we call them expert? Because just a bit of more experience, seen a lot of exams. That's why they become experts. Doubt clearing session one-to-one, though, that is no, must have right now in these circumstances. We have a student-centric approach over here. We have personalized attention. We have safe learning environment in this one-to-one doubt clearing session, right? So our teachers revise all the essential topics, provide for the MBBS exam, provide tips, answering questions effectively, and highlight important points to include, right? So this is also a special feature over here. Hard copy notes that I already told you. We have this first off mainly we have in-depth coverage. So past 10 years of PYQs, most anticipated. So If you go to for your exams, if you ask your seniors, your second year or third year, or even if your faculty is in your respective colleges, the first thing that the faculty or a senior will tell you, okay, first at least go through the PYQs. Or how many? They will say, okay, you have time, take 10 years. If not, then at least for 5 years. That is what is covered in all those notes. At least past 10-year PYQs. Then high qualified teachers over here will guide you through the concepts, answer writing skills we have discussed already, and interactive learning. So these are all the hard copy notes set that we have. Question bank also, 3 levels of expertise, and then you're beginner to expert level. So there, as I told, that a lot of in our app we have a lot is this feature of the MCQ, so that MCQs, see, MCQs is not always, don't, whenever you are giving any MCQ, don't just think, okay, this is I'm giving for preparing for PG exam or what. MCQs are multiple choice questions. They actually test your knowledge in depth for a particular topic. Simple as that. Okay. If suppose there's an MCQ, okay, what is the nerve supply of this particular muscle? And then they show you an image of, say, a deltoid muscle. They don't name the muscle as a deltoid, but they give you an image of a shoulder region with a deltoid muscle, and they ask you what is the nerve supply of this particular muscle. So in this particular MCQ question, they are testing that can you identify the muscle, and if yes, then can you identify that which nerve supplies it, right? So these sort of questions, the MCQs are very good for your self assessment. Okay, so it covers MCQs from POF exams, and as I said earlier, also for your NEET, PG or FMG. So even if you are doing MBBS from outside India, once you have to come back to India, your degree will be recognized only if you clear your FMG exams. These are foreign medical graduate exams, right? So without clearing it, you are not even regarded as a qualified MBBS doctor. So obviously, for those who are doing their graduation from outside India, they have to do FMG, right? So these questions will cover those exams as well. Now, obviously, we have also the practical sessions. Here you can see ma'am is holding the skull over here, showing us the different foramens inside the skull, right? So we have Auricle's practical classes, hands-on experience. We have Viva OSA, confidence skills, long forgotten practical classes. So this is a must-have for a subject like anatomy per se. If I say out of all the 3 subjects of first year, we all know we have phys or biochem. So in a subject like anatomy, if you have the practical sessions as well, then it boosts your knowledge, it boosts your confidence for the particular subject. I hope you agree with it, because we know that most of the colleges in India, they don't have that practical labs, they don't have the cadavers, most of the colleges they don't have. Let me tell you in sufficient amount the cadavers. So these sort of practical sessions, they help you immensely for gaining confidence in this particular subject as anatomy, because anatomy, as we all know, is most is a subject of in visualization of, you have to be a little bit more creative in understanding which organ or which structure is where. So these sessions will help. Then in the end, we have this subscription plans. We have a basic plan for around 20K, one less than 20K, standard plan for 3,499, and a premium plan for 5,999, right? We have the different time periods over here. Okay, so from 3 months to 6 months to around a year, we have all these features which are there for it, right? Last but not the least, don't forget to use the code also, Dr.Ankit 20 to get some extra discounts on your subscription if you're planning to, right? So that was all in just introduction. Let's jump to a topic. And what were the topics? Let me go back a bit over here as we have moved too much. Yeah, so these are the topics that we are going to discuss today. Mainly, let me remind you again, mainly topic is deep cervical fascia, in which a carotid sheath and nerve structures are included along with the spaces in the neck. And then we will talk a bit of the posterior triangle of the neck as well. So these are the 2 big essential topics. Okay, fine. So let's now jump to the topics over here and let's see over here. Okay, guys. So we'll start with what we are going to start with the deep cervical fascia. Here, as you see, it's written deep cervical fascia. Deep cervical fascia. Okay. So let us learn this. Let us understand this topic, right? Learning and all you can do very well if you understand a particular topic. So let us first of all take out the meaning of this particular word, deep cervical fascia. We all know from the basic knowledge that in our body, when we start the dissection, we have the skin layer. Deep to it, we have a superficial fascia. Deep to it, most of the places we have a deep fascia. Then we have the muscles, we have the soft tissues and all that. And finally, deeper at most of the places, we have the bones. Okay. Now here the term is deep cervical fascia. So basically, it is which fascia? It is a deep fascia. What do you mean by cervical? Cervical means the neck region. We have the cervical bones over here, cervical vertebrae. So basically, deep cervical fascia means it is a deep fascia of the neck. So its basic meaning is this. It is also known as what? It is also known as fascia coli. Fascia coli is another term given to it. So we have deep cervical fascia, also known as fascia coli. First thing. Second thing is we have a deep fascia at a lot of places. You have learned about upper limb. We have learned, you might have learned about the lower limb. They have deep fascias, quite a good, strong deep fascias. But in those areas, we don't go into details of the deep fascia. Here you are seeing the deep fascia of the neck is condensed to form the fall. So there are so many layers in the deep cervical fascia. So now the question should come to your mind that why is the deep fascia in the neck so important that it is having so many other layers? So there should be something, right? So what is that something? That something is, see, if you look at a neck and just understand what is inside your neck. This is a skin, right? This is a skin over the neck. What is inside the neck? Everyone knows, okay, we breathe through it. Okay, so we have a trachea, right? Then we have a food pipe, we have a esophagus, or you can say pharynx. Okay, so trachea, larynx, esophagus, pharynx, same thing. Then we have some vessels also. The blood vessel is going above. We have the carotid arteries, right? And the blood is also coming down. We have the jugular veins. Just understand. Then we have this whole vertebral column, cervical vertebrae. Yes, we have the lot of bones, right? And then obviously the neck is able to move. So we have a lot of muscles. Just understand. So in this small space, if you look at the whole body, trunk, it's a huge, right? Trunk compared to the neck is obviously quite bigger in the size, quite big in the girth. Neck is quite constricted compared to the trunk. So in this small space, we have so many vital things. Now these are vital things. Trachea, if you block it, people will die. If you block the esophagus, again there will be, you know, death. If you cut the carotids or jugular veins, blood will ooze out, again death. If the bones are over there, fractured, then what will happen? The inside the bones, what we have the whole spinal cord over here. So patient can go to quadriplegia, and the muscles over here are moving, the whole neck. So everything over here is important. So my point over here is everything over here is important, and secondly, everything is doing its work simultaneously. What does it mean? It means that right now I'm talking to you guys, right? It means that, okay, I'm speaking some words, my larynx is in some motion, right? Vocal cords are vibrating. Meanwhile, I'm breathing also, everyone is breathing. So my trachea is functioning. So my trachea is functioning, right? Meanwhile, if I just ingest my saliva, or if I take a glass of water, if I eat something, my esophagus is also working. Simultaneously, my blood is going into my head and neck, and the brain carotids are working. Blood is coming down also. Okay. I can also still move my neck here and there a bit while speaking. It happens. So the bones and muscles are also doing their job. So simultaneously, all the things are happening in the small area. Therefore, the point over here is, therefore, you need some structure which separates them a bit so that one group of structures, they don't interfere in the functioning of other group. I hope you're getting a point. One group of structure does not interfere with the functioning of other group. What does it mean? It means that if you are sitting, if you're listening to the lecture, right now, every one of you, you are breathing, right? But do you feel you're breathing in the neck? No. The blood is going above also in arteries, blood is coming down also through the veins. Do you feel it? No. When you move your neck here and there, does it compress the blood vessel? No. Does it compress the air pipe trachea? No. And meanwhile, while doing all of this, you can also take a sip of water also. Esophagus also. Everything is working working simultaneously without affecting the others. How? Because of this deep cervical fascia. Therefore, it has so many layers which separates them. So that each group of structures can work efficiently without disturbing or influencing the other group of structure. I hope you got the point. Okay. Now let us see what are the names over here. So we have the investing layer, we have pretracheal, we have prevertebral fascia, we have carotid, then we have two more, buccopharyngeal and the pharyngobasilar fascia. There are 6 words over here. Now, most of the students, while looking at the 6 words, this okay, the topic is very complicated. First of all, how do I remember these 6 words? You don't have to remember these 6 words. You have to understand the topic of deep cervical fascia, and then you have to understand that where are these lying one by one. The moment you understand one by one, and if you combine all of that knowledge, already 6 are done. Okay. Okay, sir. Easier said than done. How do we do that? Okay, for that, let me show you an image over here. Let me show you an image over here. Just give me a second. Okay, this image over here. What is this image? This is a transverse section. Which section? Transverse section. Okay, where? Of the neck, obviously. So this is a TS, transverse section of the neck region. How to understand this? Okay, let us see. This is the anterior aspect. First of all, understand the diagram. This is the posterior aspect. These are lateral, say right or left side. Lateral aspect. Okay, one side, say, let us say this is the right side, and let us say this is the left side. Okay, anterior, posterior, and the two lateral side, right and left. Now, first of all, look at the structures inside. What is this over here? This is the trachea. This is what? This is trachea. Okay, with the red color behind trachea, I'm writing O for what? Esophagus. Okay. Behind this, what is this? This is cervical vertebrae. C dot V are cervical vertebrae. Okay, so we have trachea, we esophagus, we have cervical vertebrae. And around cervical vertebrae, let me highlight, these are all the group of muscles over here, right? These are all the group of muscles which are moving the cervical vertebrae. I hope you're getting the point. Different structures. But so where are the vessels? Very good question. This on the sides, both sides, I'm highlighting the yellow color, these are the vessels. Okay. Okay. Now, what I told in the beginning that you need the layers which separate them. That will be present in the deep fascia only because superficial fascia is where? Superficial fascia in the neck is just below the skin. So that can't go deep inside, no. So you need deep cervical fascia. Now, let's start from the outside. Most outside this, let me put some two red arrows on the left side. This is the layer which is present throughout the neck like a collar. There you see my t-shirt. No, it has. Imagine this is a collar, right? This is engulfing my entire neck from behind to forward. This is known as investing layer. Okay, this is known as which layer? Investing layer. These are all the layers of deep cervical fascia. These are just the parts. So focus on one by one. Forget of all the other 5 names. Focus only on investing layer at a time. Investing layer is lying outside. What does it do? It is like a collar. Let us write collar over here. It will split where at 2 major muscles. What is this muscle over here? Neck muscle, trapezius. And what is this muscle over here? Sternocleidomastoid. So you're seeing 2 muscles over here. This is SCM, sternocleidomastoid. This is TPZ, trapezius. So this investing layer will split over here, but it is actually located outside. Point clear? This is number 1. Let us see now number 2. Now, this is trachea. We have seen trachea, right? So in front of trachea, we will have a fascia that is known as pretracheal layer of deep cervical fascia. Where it is? It is right over here. Let me put a box over here. This is our pretracheal layer. Which layer? Pre. Pre means before. Pretracheal. So what is the use of it? Very good question. What lies in front of trachea? We have an endocrine gland, a very, very important endocrine gland. That is your thyroid gland. Which gland? Thyroid gland. It has a separate anatomy in itself, but understand for now. So this pretracheal layer over here will cover the thyroid gland. Then what will happen? Then actually what happens is it will go behind. Let me make some dots over here. Can you see some dots? No, not some dots, but the interrupted lines over here, right? This is the continuation of pretracheal, which is covering the esophagus from behind. Okay, so what is this, sir? This is our buccopharyngeal fascia. Buccopharyngeal fascia. Got the point? This is the buccopharyngeal fascia. So we have a pretracheal layer, which is actually covering behind, also behind the esophagus or the pharynx. We call it as buccopharyngeal fascia. So now let me tell you, show you over here. Actually, this whole area is under pretracheal fascia, which includes the thyroid gland, trachea, esophagus, mainly these structures. I hope you're getting the point. Investing layer was outside. So we have covered 2. Investing layer was, we have understood 2. We understood 2. Investing layer invest from outside. Then we have the second deeper layer known as pretracheal layer. This is pretracheal layer. Let me highlight with yellow color over here so that you remember pretracheal layer. Point clear? Now, what is the centermost point, or what is the structure lying exactly in the middle or most deep? Is the bones, right? If you look at the upper limb also, we have the radius ulna over here, humerus over here. So in the neck also we have the cervical vertebrae. Okay. Now cervical vertebrae, it needs some movement also. You have prevertebral and postvertebral muscles, right? And therefore, as a functional group, it is a different group. So therefore, my point over here is this whole area should be covered by some fascia. I'm just highlighting the orangish color over here, right? This is the whole thing over here. And if we change the color over here to say this color, this is your which fascia? Prevertebral fascia. Which fascia? Prevertebral fascia. Let me highlight it also. Okay. This is the prevertebral. Can you see this prevertebral layer? This is the prevertebral layer over here. Let me put some more arrows. This is the prevertebral layer over here. It is before the vertebrae. It's covering the entire vertebrae and associated muscles. So this is the deepermost layer. So we have covered 3 layers: investing, outside like a collar, pretracheal, in front of trachea, in fact covering the thyroid gland also, and prevertebral. Third one, as the name suggests. Now, see over here. Now, let me take, say, red color only. The pretracheal layer from here. Can you see this area, pretracheal layer? The prevertebral layer from here and the investing layer from here. Can you see this three red color areas which I'm trying to make over here? These are 3 different fascias. One over here is apart from the investing layer. One over here is apart from the pretracheal layer. One over here is apart from the prevertebral layer. And all of these 3 are close to what? They are close to the carotid arteries over here. And they are close to what? They are close to the jugular veins over here. Therefore, these 3 contribute to form the carotid sheath over here. What is this? This is carotid sheath, right? Let me highlight the carotid sheath name for you guys. This over here is the carotid sheath. Okay, this is the carotid sheath. That is the 4th layer. So carotid sheath is actually not a separate, but it is formed from these adjacent deep cervical fascia layers, investing, pretracheal, and prevertebral. They contribute to the formation of carotid sheath. Point clear? So we have covered 4 fascia. 5th fascia by name we have covered is buccopharyngeal, right? 5th fascia by name we have covered is buccopharyngeal fascia. And last one, I guess, was pharyngobasilar. Right? Let me write its name also. So let me number it. First, investing layer. Second, pretracheal. Third, we talk of prevertebral layer. Fourth, we said carotid sheath. And pretracheal, we had this buccopharyngeal fascia as well. We have buccopharyngeal fascia as well. Let us name it, number it as number 5. Number 6 is pharyngobasilar fascia. Pharyngobasilar fascia. Okay, sir. So where it is, sir? That should be a good question. The question should run to your mind, sir. Where is pharyngobasilar fascia? Help us in locating it. Okay. So what do you think? What from the name, where it should be? Pharyngobasilar fascia. It should be between the pharynx and some base. What base? Base of skull. Base of skull. Okay. So when we have this pharynx, no, pharynx is the upward continuation of esophagus. So we have 3 parts of pharynx. The lowermost part is known as laryngopharynx, behind the larynx. Above it, what we have? We have the oropharynx, behind the oral cavity. Above it, we have the nasopharynx. And what is present below it? Below, we have the red color I'm writing esophagus, right? So we have the 3 parts of pharynx: laryngo, oro, and nasopharynx. Above this nasopharynx, we have this base of skull. What we have? Base of skull. Okay. So what actually happens, guys, is that you have a very small fascia over here between the base of the skull and the outer layer of pharynx. This is what is known as, I hope you got the point, this is what is known as pharyngobasilar fascia. So that was our 6th layer. Okay, so I devoted this time over here, I invested time over here for you to understand the fascias. Understand always one by one. Don't understand all 5 or 6 at one go, else you will confuse. Right? So understand first investing layer, forget everything else. Okay, now you are through investing layer, okay, done. Then think about the next layer, pretracheal. And with the pretracheal, you have the buccopharyngeal fascia. Then more deep, if you go, think about the, okay, what is deepest? We have the bones prevertebral. Okay, and all of them will contribute to this for the carotid sheath. And finally, we have one which is known as pharyngobasilar fascia. This was the understanding that you guys need, right? Now let us go to the notes and let us see what are the things, other things that are there in the notes and that can help us around. Okay, so you've seen the 6 layers over here. Okay, here is an image now. Previous image, what you saw TS, transverse section. This image, what you're seeing a longitudinal section. So what it will tell us? It will tell us the vertical extent. Vertical extent basically is mainly in the neck region. So most of the fascias over here, they will start somewhere around the skull, the lower part of the skull, right? Or the mandible, or say the hyoid bone over here, or say the mastoid process. So this is where the head and neck joins. So most of the fascias will start from here, and then they will go down up till the beginning of the thorax or the upper end of thorax, which will include, say, your clavicle, sternum, your arch of aorta, adventitia, around the blood vessels, all of that. So, okay. So let us see one by one over here. Understand. Let us understand one by one. We have the prevertebral fascia. You can see from where to where it is coming longitudinally. From here, it is going down to this thoracic, even thoracic vertebrae. Okay, it is up till T4. This is up till this is which vertebrae T4. Okay, so it starts on the base of the skull. Then you have this prevertebral. Then you have the investing layer again, it is present all around. So behind also, because we said that it is investing layer is present all around like a collar. Okay, it is present all around like a collar. So it is present behind in the occipital bone, and anteriorly it is attached to mandible. And below it will go attached to the sternum and other areas like sternum, okay, clavicle, then you have the scapula, all that. Investing prevertebral, and then you can also see at the pretracheal layer. Okay, pretracheal in front of trachea. You can see this whole larynx, and below larynx with the trachea over here. So it is present in front of the larynx and the trachea. It starts from where? Starts somewhere from around, you can say, the hyoid bone above, and goes down and merges with the adventitia around the arch of aorta. So below we have this arch of aorta. No? Understand this part. That what will we have below over here? Over here we have the arch of aorta. Where is our arch of aorta? Arch of aorta, guys, is actually behind the manubrium. I have made it a bit lower down. Let us make it a bit higher up over here. This is the manubrium over here. So behind the manubrium sternum, behind the sternum, upper part of sternum, we have the arch of aorta. So you can see this fascia pretracheal, it actually merges with the adventitia over here. Okay, I hope you understood why we have different layers, where actually they lie. Where actually do they lie? Fine. No, all of this knowledge, then some of you who are smart enough will think, sir, fine, we understood a bit. We invested our half an hour, 1 hour. Fine, but why? Why is the need of this knowledge imparted onto us? Is it only to clear the exam? That is an important part, but that is not an ideal student should not always look, okay, clear the exam, clear it is, you are doing the degree for knowledge, obviously, right? So why is this knowledge important for a medico? The reason is that between all these layers, you have different spaces. What you have different spaces, okay? And sometimes or many a times there can be pus collection or infection in these spaces, right? So you as a doctor, after examination or after investigations, should make out, okay, which space is having the collection of pus. So how do I drain it? Right? You should know that. How do you drain it? Because suppose there's a pus collection in the neck. Now you are unaware, okay, where in the neck? How do I know? You can't just cut the whole neck up, open up. No? You can't just open up the entire neck and see, okay, where's the pus? That doesn't how the things are done. That is not the way. So therefore, you should know. Is it in the retropharyngeal space? It is in the parapharyngeal space, prevertebral space. There are so many spaces also. We'll see. So this is the applied aspect. Why do I know? Why do I require to know? The second point is some of the spaces from here, infection or pus collection can directly come down also. Where can directly come down? In the region of the mediastinum. Okay, so you have infections in the neck, which can even come from the mandible because it is attached above. So, and mandible, what we have? We have the teeth over here, right? With the teeth and gums over here. So infections right from the teeth or gums can go to the neck and can go to some places by which they can come down, and they can even go to mediastinum. So just imagine for a second. So these are the scenarios which can happen. A tooth abscess. Suppose a tooth abscess, patient went to a dentist, a tooth abscess, and somehow the treatment didn't went fine or whatever, or the immunity was low for the patient, and after some weeks presenting with mediastinitis. Just imagine, this is how the body is made up of, right? So you can imagine that, right? This can happen. This is where this knowledge will help you. How can the infection go? Where should I drain it? Where to act? Okay, fine. Okay, now let us see some theory part over here. So investing layer, It lies deep to platysma and surrounds the neck like a collar that we have done. Now we have done the hard part, guys. So be happy. We have done the hard part. Now let us do the theory part, understand a bit. So investing layer, it is deep. Platysma is a muscle which is beneath the skin. So it is deep to the platysma, surrounds the neck like a collar. It forms the roof of the posterior triangle. Okay. So we have the triangles also that you'll see, and it forms a roof. Why roof? Because the investing layer is the outermost layer. It is the outermost layer of deep cervical fascia. Okay, so there are triangles with there are spaces in the neck outside. Okay, we call this as posterior triangle or anterior triangle. Okay, so if you imagine the collar over here, it is forming the roof of all the triangles. So it will not only form the roof of posterior triangle, it forms the roof of posterior triangle and also the anterior triangle. Okay. Attachment over here, attachment I already told you, you can just go through it. Superiorly, it is attached to all these bony landmarks. Inferiorly attached to clavicle, manubrium, all that. Behind attached to the ligamentum nuchae and anterior attached to the mantine hide. Okay. Rule of two, this is what you can remember. This is not a very something, this just like a mnemonic help in your understanding. That is, investing layer splits to enclose two muscles. These are two muscles, as we discussed. It also encloses two salivary glands, and it also has the two spaces. One is suprasternal space, one is a supraclavicular space. Suprasternal space is a very small space just above the sternum, that is known as also space of bone. So this is, imagine the manubria sterni, and this is a small space which happens. Why? Because see, investing layer actually bifurcates. So sternum is a bone, it will attach to the anterior and posterior end of sternum. So here the small space is developed. Just theoretically understand, known as space of bones. Okay, this is investing layer and this is a diagram not needed. And second, pretracheal layer. So we all obviously covered it. Pretracheal fascia encloses the thyroid gland because it is lying right over here. This is my thyroid gland location and forms its false capsule. Once you learn about the thyroid gland being an endocrine gland has its own capsule that is known as a true capsule. But as we have seen that apart from having its own capsule, outside it is also covered by another fascia, so that is regarded as false capsule. So what is false capsule of thyroid gland? The pretracheal fascia. And it continues behind us. We have seen that, right? That pretracheal fascia was continuing behind as buccopharyngeal fascia. In between what we had the trachea and esophagus. And this is the thyroid gland was inside this. Remember? Attachments again, superior, inferior, or either side. You can see all the attachments that we have seen. I'm not going to again for this. One important point, though, again we'll discuss in the thyroid gland topic, this is known as structure is known as ligament of Berry. What actually happens is, if you have seen or thyroid gland examination, you will remember that once you put your hand, palm of your hand in the front of the neck over the thyroid gland, and you ask the patient to take 1 or 2 sips of water. As the patient takes a sip of water, obviously the larynx will move. Okay, why does that happen? That also is a different thing. Those are all the stages of swallowing. While swallowing, the larynx will move. Why I'm keeping my palm of the hand over here? Because with the larynx, the thyroid gland will move. How? Because of this ligament of Berry. This is the reason why with the larynx moving, the thyroid gland also moves. So if you place a palm, if there are any nodules in the thyroid gland, it will rub against your palm and you might feel it. That is the examination finding, right? So ligament of Berry. Okay, so posterior layer of the thyroid capsule is thick on either side, forms suspensory ligament on the thyroid gland. Basically, there's a ligament of Berry which goes from thyroid gland to where? It goes from thyroid gland to cricoid cartilage. It is attached from there to there. Okay. Right. Okay. So here's an image also shown. This is, see over here. Let me highlight it. This is the thyroid gland. Okay. You have this false capsule. So what is this? This is pretracheal fascia actually. And then you can see behind you have the cricoid cartilage over here, and here is this ligament of Berry. So as the larynx will move up, the thyroid gland also will move up like this. This is how the examination is done. So see how slowly your knowledge will help you in different applied aspect. Next, the deepest was the prevertebral fascia. So it lies in front of prevertebral muscles and forms a floor. Now this is forming the floor. Why? Because it is more deep. The investing layer was forming what? It was forming the roof. The prevertebral fascia is forming the floor. Okay, so if you imagine some structures over here, right? Just imagine there is an artery going over here inside this carotid. Now, this area, which part of the deep fascia will form the roof? Investing layer. But deep inside, we have the bones, prevertebral or the vertebral bones and prevertebral muscles, and that will be covered by prevertebral fascia. So the floor will be formed by prevertebral in this area for that particular artery, and the roof will be formed by the investing layer. This is as simple as that. Okay. Again, the attachment superiorly you can see it is at the base of the skull. Inferiorly goes and splits into a couple of layers. Anteriorly, it is separate from pharynx by buccopharyngeal fascia and retropharyngeal space. We'll see that. Or let me just show you. Forget about seeing it later. Again, remember the TS of the neck transection. This was, imagine, pre-tracheal fascia. This is trachea, that is esophagus. Okay, this is trachea, that is esophagus. Okay. Then we said that this pre-tracheal fascia continues as what? Buccopharyngeal fascia. This is BPF. Okay. If you remember more, then you will remember that here we had one more fascia covering the prevertebral muscles, prevertebral fascia. Now see over here, what will be this space called as? This is behind the pharynx, known as retropharyngeal space. Now see the wordings over here. This is the anti-attachment of prevertebral fascia. Okay, it is saying it is separated from the pharynx and buccopharyngeal fascia. So this prevertebral fascia is separated from buccopharyngeal fascia by retropharyngeal space. So this is retropharyngeal space. Why is it retro? Because it is behind the pharynx. But it's a various pharynx. But this is esophagus. Esophagus is the continuation of pharynx. At the level of say C7, T1, you will have esophagus. But at C4, C5, C6, C2, you will have pharynx. Okay. So above C6, we have pharynx. Just imagine esophagus and above it, we have pharynx. This is the retropharyngeal space. Understand this. Okay. Okay, I hope you're getting the point. Now, remember these few points over here. Other features, there's an important 3-4 features over here. The trunk of the brachial plexus. Brachial plexus, you all must be knowing. We discussed in the upper limb. It lies between the prevertebral fascia, between the scalenus and anti-scalenus median muscle. We'll see that in images as well. The prevertebral fascia is pierced by cutaneous branches of cervical plexus. If you don't understand it, then you'll start to cram it. Then it becomes a problem. How to understand it, sir? Okay. See, this is, imagine over here. This is, say, I'm making a circle. This is cervical vertebrae. Just imagine. Inside cervical vertebrae, what we have this yellow color, what it could be? It will be our spinal cord. Spinal cord. Okay. What will be this layer known as, which is covering the cervical vertebrae? What will be layer? What is this deep cervical fascia layer? Prevertebral fascia. Right? Prevertebral, so covering the vertebrae. This spinal cord. Now, what will come out from the spinal cord? We have the cervical plexus. So, what will come out of it? You have the cervical spinal nerves. So, they have to reach where? If they are cutaneous branches, they have to reach the skin. Where is skin? Skin is more superficial. So, these nerves, they have to reach the skin. So, they have to reach the skin. So, they will pierce which structure? They will pierce this prevertebral fascia. You're getting a point? So these nerves which are coming from the spinal cord, they have to come out piercing this prevertebral fascia to reach skin if they are cutaneous. So what is written over here now, understand. The prevertebral fascia is pierced by 4 cutaneous branches of cervical plexus. Understood the point? That is the point. Axillary sheath, if you remember, we studied in axilla part of the upper limb. Axillary sheath, the question has come, is actually a continuation of prevertebral fascia. Okay, remember that. Prevertebral fascia provides a fixed base for movement. So as we discussed that, why do we have so many layers of these cervical fascia? The reason is this. It provides a fixed base so that it doesn't get disturbed or it doesn't disturb the other structures. That is as simple as that. So that the pharynx, the esophagus, the carotid sheath, they can easily function without interfering with the functionality of other structures. If you're getting my point, right? They have seen this TS over here. Carotid sheath, as we discussed that, okay, we have this other layers, they will all come and form the carotid sheath. So it is condensation and formation. NTS will be a prevertebral fascia, posterior prevertebral, and let me add over here on the sides, we have investing layer also. So this investing layer also will definitely help in giving some part of the carotid sheath. Contents, frequently they ask, artery, we have either common carotid artery or we have internal carotid artery. Do remember over here in bracket I'm writing External carotid artery is not a content of carotid sheath. Do remember this. Then you have a vein, internal jugular vein, not external jugular, internal jugular, and you'll have a nerve inside known as vagus. That is the 10th cranial. Okay. And do remember over this is for the PG level questions. This arteries over here, they are placed medially in the carotid sheath. And this vein over here, it is placed laterally in the carotid sheath. Now again, sir, why do we need to know this? Just for solving MCQ? No. For this internal jugular vein, sometimes you have to do a IJV catheterization. Yes or no? So where would you try to locate it? If you can feel the carotid, you know, just lateral to it, I should have my internal jugular vein. So you should have basic idea of this. Many times carotid angiography is done. Okay, you should know in CT images also where to look for these vessels. For even for ultrasound, for Doppler, if you are doing for a carotid, you should know where to look for. So basic anatomy is needed everywhere, guys. So do remember in this upcoming, not the upcoming, even in present times, so many investigations have come which tell us so beautifully the anatomy of the body. But you can only understand the investigation if you know the basic anatomy. Suppose you are not aware of the basic anatomy, then no matter how good an investigation comes in front of you, what will you decipher out of it? There's a very famous proverb. And that very famous proverb is that eyes see what the mind knows. So this is the training over here for your mind. So that tomorrow your eyes start to see what you want to see. Normal as well as abnormal. Okay, only you can see the abnormal if you know the normal. If you don't know the normal, then you can't judge abnormal. I hope you're getting a point, right? Okay, so these are the relations, anterior and posterior in the carotid sheath. What we have? Anterior, we have the ansa cervicalis. That is again a loop of nerve. And posterior, we have sympathetic chain. So this is also asked in a question separately. These are the images over here for carotid sheath. Here, look carefully. This is the common carotid artery, and soon as it bifurcates, you can see ECA is outside the sheath. Yes or no? IC, this is the IC that is inside the sheath. Laterally, we have internal jugular vein. Between, you can see this yellow line. That is a vagus nerve. Okay, that is a vagus nerve. Okay, and if you take a TS of the carotid sheath, and if you take a TS, that is transverse section of the carotid sheath over here, then here you see that anteriorly we have the ansa cervicalis over here, loop of nerve, and behind we have the sympathetic chain. Posteriorly, we have the sympathetic chain. Okay, I hope this much point is clear. Okay. Pharyngeal spaces, just go through this pharyngeal spaces. Retropharyngeal space, we already have seen where it is. It is a dead space behind the pharynx. So this was the pharynx, that was a prevertebral fascia, and between you have a retropharyngeal space. Okay, understand it. Boundaries, anteriorly we have the buccopharyngeal fascia, posteriorly we have the prevertebral fascia, on the sides with the carotid sheath, superior base of skull, inferiorly open over here. So let us see in this diagram also where we have seen that TS was above, no? Just a second, yeah, over here. So let me just shade it with the red color. This is your retropharyngeal space. Which is space? Retropharyngeal space. So what they are saying, anteriorly buccopharyngeal fascia, posteriorly prevertebral. On the sides, they are saying carotid sheath. Absolutely correct. Okay. On the sides, we have the carotid sheath over here. Above, we have the base of skull, because prevertebral fascia all goes to the base of skull, inferiorly opens into superior mediastinum. Understand? That is continues to the superior mediastinum. Contents, again, we have the loose tissue over here, some lymph nodes, some vessels and nerves. Clinical anatomy, as I told, that pus can be collected due to lymph node abscess. So as it has lymph nodes, obviously there can be abscesses in the lymph nodes. Understand? Which lies in pyramidal position. Okay. So here they are again trying to show you the retropharyngeal space. This is the retropharyngeal space right over here. Okay, so anteriorly of the pharynx, behind you there is vertebrae, prevertebral fascia, and this is the retropharyngeal space. Other space is also there. Laterals on the sides. In fact, they are saying that it's located at the side of the pharynx. Fair enough. Boundaries are what? So medial, it is medial, not medical, it is me. So medially or inside you have the pharynx, because it is lateral pharyngeal space, or also known as parapharyngeal space, parallel to the pharynx. So medially you have the pharynx, posterolaterally you have the parotid gland, which you can feel over. This is the parotid gland. Anterolaterally you have the medial pterygoid muscle. Okay, we'll see in the image, or we'll see the our images investigation, but here also there's an image. Let us see it also. Okay, let me just enlarge it a bit. In this image, they are trying to show us what? Lateral pharyngeal space. Okay, let us try to see. So this is the area for the pharynx. Okay, you can see this carotid sheath. Okay, this will be, say, the pharynx is right somewhat over here. This area for pharynx, your nasopharynx, right? This area of pharynx. This is the parotid gland, which they said is posterolaterally, and this is the medial pterygoid muscle. So you can understand the parotid gland, and also look at this muscle over here. And this is the mandible, and this will be the medial pterygoid muscle. And therefore, you have this space over here. It is already labeled over here. This area over here. This is the lateral or the parapharyngeal space. So now some of you might be wondering, sir, do I have a space right now in a normal person? Do they have spaces? No. These are all actually what? These are all what is said to be having the potential spaces. What does it mean? That these are potential spaces. Likewise, like if you are in first year, if I say you guys have the potential to crack the NEET PG exam and get the top 100 rank, I'm saying you are a potential NEET PG toppers. So it doesn't mean that you are NEET PG toppers right now. But if you grind yourself in your whole this MBBS journey, you can be a NEET PG topper. So you are a potential NEET PG topper. Similarly, these are potential spaces that tomorrow if there's some collection of fluid, only then this space will come into picture. Else it is bounded by all these soft tissues. But tomorrow if there is any fluid collection, then this space will come into picture, potential spaces. I hope you got my point. So normally also pharynx is, the buccopharyngeal fascia is actually, there's gliding in front of prevertebral fascia. But tomorrow when the lymph node abscess will come, then there will be some potential spaces. Okay, and that is where the abnormality will come. That is when the patient will come to you. Okay. Clinical anatomy again, can look over here. You have Ludwig's angina, first flash on the floor of mouth. These are all the clinical things which you will learn more in ENT. Okay, so that will go to other spaces, right? So this was, I guess, I discussed about the deep cervical fascia. Deep cervical fascia, it's a big topic. Go through it. Go through what we have discussed today, and then let us now continue with a bit of our posterior triangle also, right? Let us look at the posterior triangle. Just give me 1 second. Okay, right over here. So now, what are these triangles? Let us just give an overview today, and tomorrow we'll discuss more of the triangles. So we have done about the deep fascia. So what we have covered by now, we should be proud of it, that we have covered the deep fascia of the neck. Above it, we have the skin and superficial fascia. Fair enough. Now, neck is divided into triangles. But why, sir? That should be your first question. Why are we dividing? What is the use? We don't divide the arm into triangles or trunk into triangles. The reason is because there are various small and important structures in the neck everywhere. Likewise, you have larynx, you have so many carotid vessels, you have salivary glands, you have thyroid gland, you have some axillary nerves, you have so many structures lying around over here. And therefore, you need a particular distinction to separate them. That is why triangles have come into picture. Now, this is the lateral. We can see the anterior aspect and the posterior aspect, right? There's this muscle over here. This muscle, let me highlight it. This is okay. You guys tell me which muscle is this. Think about it for a second, and then I myself answer. This is sternocleidomastoid. Okay. If you rotate your head like this muscle is sternocleidomastoid. Similarly, behind over here, you have this muscle. Okay, this muscle over here, that is trapezius. Okay. Understand that the in front of sternocleidomastoid, this whole area, this whole front of neck, bounded behind on both the sides by sternocleidomastoid. So this whole area over here, this whole area is what is said to be the anterior triangle of neck. Anterior triangle of neck. Okay, this whole area over here to here, everything over here, from the mandible to the sternum, in front of sternocleidomastoid, both the sides, this whole area is the anterior triangle of neck. It's not a very big achievement. It's very straightforward. It is lying anteriorly. Okay. In comparison to it, between the sternocleidomastoid and the trapezius, basically it is lying more laterally. It is actually posterolaterally. But in comparison to anterior, we call between the sternocleidomastoid and the trapezius, this whole area as the posterior triangle of neck. And this basic things is what we have to go through it. So forget about the anterior triangle, that will cover in the next topic, probably tomorrow. focus more on this posterior, this entire is a posterior triangle. And as you can see in this image only, that you have this muscle over here. Can you see this muscle? This is a muscle. This is actually inferior belly of omohyoid. This is inferior belly of omohyoid muscle. This anatomically separates the entire posterior triangle into a superior occipital triangle over here. You can see this entire is occipital triangle. And this lying below over here, this is the small triangle. This is wrongly labeled over. Let me correct it. This is known as your subclavian triangle. Subclavian, also known as supraclavicular triangle. Supraclavicular triangle. Okay. Supraclavicular. Some error, printing mistake. Don't worry too much. So inferior belly omohyoid separates or divides the posterior triangle into a much bigger occipital triangle and a smaller but significant subclavian triangle. Okay, now you might be wondering, okay, sir, posterior triangle we understood. There's a muscle inferior belly omohyoid, fine. Why do they have given the names like occipital? Because guys, understand here, do we have occipital bone? No, occipital bone is right over here. Then why this triangle over? Because this over this area, we have a very important artery which runs, that is occipital artery. So they just gave it a name. Okay, fine. But why we are calling it a subclavian triangle? Because here you have the subclavian vessels. Yes. So this also gives you an idea. Suppose tomorrow you have to do a subclavian catheterization, or you have to block the subclavian artery. Where would you go? Just above the clavicle. Where is clavicle? This over here. Because the sternocleidomastoid and trapezius both are attached to clavicle. Sternocleidomastoid to the medial aspect of clavicle, trapezius to the lateral aspect of clavicle. So therefore, this bone is which bone? This bone is the middle third of clavicle. Which clavicle? Middle 1/3 of clavicle. You can feel it. See, these muscles are so huge that you can feel it. And if I ask you right now, which fascia was covering the sternocleidomastoid and the trapezius? Think about it. We just covered it half an hour back. The answer will be investing layer of deep cervical fascia. This covers up the histo muscles. Okay, so you know, okay, just above the middle part of clavicle, if I show you, this is my whole clavicle from medial side. If I'm palpating, that goes to the lateral side. This is my middle, center, middle part of the clavicle. Over here, if I do a deep palpation, deep inside, I have my subclavian vessels. Okay, subclavian vessels over here. Okay. Now, we understood this from the image that we have a triangle bounded anteriorly by sternocleidomastoid and posteriorly by trapezius. Below my middle third of clavicle, that is the posterior triangle. And that is being divided into two triangles by which structure? By the structure inferior belly of omohyoid. Into which two triangles? One is the occipital triangle and one is the subclavian or supraclavicular. This one all is sufficient? Okay. Before going to below notes over here, if I ask you, okay, this posterior triangle we are discussing, fair enough, sir. Tell me in the posterior triangle, which fascia will form the roof, which fascia will form the floor? We have done it. That is why I'm asking. Now, don't say, okay, sir, you asked too many questions. I ask either the logical questions, which you should know, or which we have just discussed. If you're not able to answer, it's your fault. And if you're able to answer, it's good. The roof will be mainly formed by the investing layer outside, close to the skin. Floor will be formed by the prevertebral fascia. This is prevertebral fascia. Both are parts of deep cervical fascia. Okay. Now let us look at the notes. With this basic understanding, we can look at the notes. It will help you. Boundaries. Anteriorly, we have sternocleidomastoid. Posteriorly, we have trapezius. Below, you have the middle third of clavicle, and above, see, both of these muscles, sternocleidomastoid and trapezius, are coming from the occipital bone. So above, you will have what? Meeting point. This is basically which bone? This is actually part of the occipital bone. This is actually part of the occipital bone, right? Okay, so again comes the point over here. Roof by investing layer of deep cervical fascia. Okay, the structures piercing the roof. Now, think about it. What would be the structures over here? Okay, just give me a second, guys. Just give me a second. Okay, back. So, the structures piercing the roof. Understand over here. Imagine this is the outside skin. This is the skin of the posterior triangle. Clear? Okay. beneath the skin, I am saying, okay, this is my superficial fascia, right? Then I'm saying, okay, after that, I will be having what? I will be having my investing layer of deep cervical, because that is the roof, right? So it is investing layer of deep cervical fascia. Okay. Deep inside, I'm saying this forming the floor. So it is what? Prevertebral fascia. We are seeing which triangle? Imagine we are seeing the posterior triangle. Now comes the point. If I put a highlighter over here, green highlight, what is this? This is the content. This is the space of the posterior triangle. Yes or no? Yes or no? So there will be some structures over here. There will be, say, let me make this 3 circles over here. These are suppose 3 structures randomly. If these 3 structures, 1, 2, and 3, they have to come close to the skin. Yes or no? Suppose 2 of them have to come close to the skin. They have to pierce which fascia? This purple color or this red color? Straightforward answer. This is purple color. They have to pierce what? Structures piercing the roof. Simple as that. Are you getting a point? The structures which have to come close to the skin, they need to pierce the fascia that is forming the roof. That is the whole point. Now let us see what are those structures. 4 cutaneous. See again, simple as that. Cutaneous branches. We have discussed that already. Why? Cutaneous branches of cervical plexus. These are the 4. And there's also this superficial vein. Okay. We also, this external jugular vein is not like internal jugular vein. Internal jugular vein is a deep vein. It is lying in the deep fascia, carotid sheath. External jugular vein is a superficial. It is a superficial vein. Okay. Then let us see the floor. Floor meaning by, see over here. This is the prevertebral fascia. It forms the floor. It forms the floor, right? So here what we will have some muscles over here. What will have some muscles over here? Why? Remember, prevertebral fascia was covering what? It was covering the prevertebral muscles, the muscles around the vertebra. What do these muscles do? They are going to rotate the neck, move the neck. Okay, so this floor, these are all the muscles which are lying. Learn few names and see in the diagram. Semi-spineless capitis. These are not very famous muscles, but for posterior triangle, you need to know these names. Semi-spineless capitis, splenius, levator scapulae, scalenus medius, and in fact, the first vegetation, most lower down might be or not be, but these 4, they do always lie. Semi-spineless capitis, splenius capitis, levator scapulae, and scalenus medius. Even you can see a bit of scalenus anterior as well. You will see. Okay, here is the triangle of the neck, posterior triangle of the neck that we are seeing. I guess we already have covered this. This also we have seen. The inferior belly of omohyoid, okay, divides the posterior triangle into big occipital triangle and not so big supraclavicular or subclavian triangle. Here, see, let me highlight it so that you start to recognize sternocleidomastoid and trapezius. So this is whole the content showing us what? The content and the boundaries. And below you can also see the contents and the boundaries. So you can see all these contents are over here. So these nerves, say great auricular nerve, right? This left occipital nerve, they are the cutaneous branches. So they are piercing the roof. They are piercing the roof. Then can you see the spinal to accessory nerve, 11th. This is XI, that is the 11th nerve over here. This is the most important clinical structure over here. What again I'm writing? Spinal root of accessory nerve. It is forming mainly the content of the posterior triangle. Now, why is this so important? If you remember, then this nerve is a motor nerve and it supplies 2 muscles, sternocleidomastoid and trapezius. So it is motor to these 2 muscles. So both of these muscles, sternocleidomastoid and trapezius, they are innervated by this particular nerve. And this nerve forming the content, but it is very close to the roof. It's very close because see, roof we have investing layer is split to enclose the 2 muscles. So nerve automatically will be very close to the roof. But this nerve is not a sensory, it is a motor nerve. If tomorrow there is a damage to some sensory nerve, there will be some paresthesia over there, but they are dermatomes which are so overlapping, the patient might normally does not come to the OPD with those symptoms. If suppose on a small cutaneous nerve is damaged, patient doesn't feel much of it. But if the motor nerve is damaged, this muscle, these are huge muscles, sternocleidomastoid, trapezius, these muscles will be paralyzed, then the patient will rush. Okay, so therefore this nerve becomes very important. And what happens is, in this posterior triangle, you have various lymph nodes also. And if there's some abscess in this lymph nodes, or normally clinically, I'm telling you, a lot of biopsies are done. Normally, the pathologist does a lot of biopsies. Suppose there is Hodgkin's lymphoma, or there's some other cancers around head and neck. You have to take a biopsy from here to look. Then, while doing these biopsies, the pathologist or the surgeon has to be very careful not to damage the spinal root of X-ray. That is the whole point, and this is why the questions do come. Okay, understand this, right? Okay, so these are all the contents. Remember to make the diagram. Let me just go through one by one. You can see the extrajugular vein over here. You are seeing the subclavian artery. Therefore, the below triangle is subclavian triangle because you have subclavian vessels over here. You have the brachial plexus also over here. Okay, with subclavian artery. See, subclavian artery, some of you might be confused over here. Let me help you. Subclavian artery continues as axillary artery. And if you go to your axillary topic, axillary artery, around the axillary artery, we have the brachial plexus, the cords come from the trunk. So you can see over here. You can see over here, the trunks are close to the subclavian artery. That will become axillary artery. You know, the trunks will ultimately form the cords around the axillary artery. Okay, let us see more structures. You have the superficial arteries, right? You have the splenius capitis. These are all the muscles forming the floor. From top, if you start, you have the semispinous capitis. Then you have the splenius capitis. Then you have the third muscle over here, levator scapulae. Then you have scalenus medius over here, fourth muscle. As I said, in front, you will also encounter scalenus anterior also. And behind, you might encounter scalenus posterior also, fifth or sixth over here. And these few muscles, they are forming the floor. They are all behind the prevertebral fascia. Prevertebral fascia is where, sir? These are all the muscles, no? These are all covered by prevertebral fascia. Simple as that. So here the investing layer is removed to show you this. Okay, here again, similar diagram. Subdivision, we have seen contents. Now see the contents over here. Now you can make a table. Now this is how you can easily answer in the exam hall also. In the occipital triangle, we have contents. So above omohyoid, that is the occipital triangle. See, spinal axillary nerve. This is most important clinically. Focus over here. Questions will come. These are all the cervical branches, providing branches to all these muscles, nerves, some superficial arteries over here, and finally occipital artery. May I ask you, it's a branch of which artery? Okay, if you are listening to this lecture, if you know, answer in the comment box. Okay, this question, I'm not telling you the answer over here. That is your homework or your screen work. It is a branch of, okay, write in the comment box if possible. And if you don't know, search it. Okay, search the answer, then write. In the subclavian triangle, we have the contents, subclavian vessels. That is why this triangle is known as subclavian triangle. Then some of you might say, sir, why then we call it a supraclavicular? For the simple reason that it is lying above the clavicle. For the simple reason that this small triangle is lying above the clavicle. So location wise, we call it as supraclavicular, but content wise, we call it as subclavian. So there are two names, but both have their meanings. We have the brachial plexus over here, applied anatomy. See over here, applied anatomy. Doing removal or biopsy in the posterior triangle, spinal axis nerve, maybe this is the clinically important nerve. First collected now. Now my next question is, yeah, right. That if this nerve is damaged, how will the patient present? If this nerve is damaged, basically there will be problem in the trapezius of that side, and this will lead to weakness. I'm using the word weakness in overhead abduction of shoulder. In overhead abduction of the shoulder. What does it mean? Meaning by this movement. You can see my left arm going above my head, overhead abduction. There will be weakness. Why I'm saying the weakness? Because the other muscle which does this, which is that other muscle, serratus anterior, is okay. So there's movement, but there's weakness. How will the patient tell you? What is the symptom that patient will bring? Patient will say, so when I wake up in the morning and when I take a bath and when I start to comb my hair, if it is on the right side, then sir, there's some weakening. I don't know why. Then if I go to kitchen and I have to make my breakfast, if I open the drawers, and there's some weakness in doing this activity. These are the things, okay, which the patient might come and ask you guys. Okay, and the question. So guys, this was the topic that we discussed today. So 2 topics. I hope you revise it and do give me an answer in the comment box if you can possibly. So revise these topics: deep cervical fascia and our posterior triangle. Okay, and then you'll come to the other triangles, anterior triangle, other glands and all. So that's all on my side, guys. Thank you for your time. Again, let us see this particular slides over here. Okay, so these are all the recorded classes, live classes, and yeah, these were the subscription plans. Below, you can use the code also. That's all on my side. Bye bye. Good night. And these are all the our social media handles. Don't forget to follow them. Bye bye. Take care.